Good afternoon, all. Thank you for coming out tonight, this afternoon. Welcome to the Community Grand Rounds. On behalf of Pastor, I would like to thank you for coming out to Coppin A&E, and we'd like to thank Coppin for offering their space for this event. My name is Brandon Johnson. I'm the Executive Director of the Washington Park Consortium, and on behalf of the consortium and the residents and organizations of Washington Park, we would like to welcome you to our community. Today, we will be having a much needed and fruitful discussion about women's health, particularly breast cancer and cervical cancer. And we would like to thank you all for taking this proactive step in helping us all to be healthier communities. So give yourself a round of applause. I'd also like to acknowledge the Urban Health Initiative, Dr. Miller, her staff, Dr. Whitaker, and all of the community consultants that work so hard to plan these events throughout the year. So thank you all. I think I should do a plug for the organization that I also sit on the board of, the Metropolitan Chicago Breast Cancer Task Force, and the work that they're doing to raise the awareness and to correct some of the issues we have around disparities in health for minorities, particularly African American women in breast cancer. So thank you for all the work that you guys do. We're going to get started. We have a good program for you. We hope you enjoy. At this time, I am going to introduce the spoken word artist that's going to set off our event, Miss Felicia Simpson. Miss Simpson is a native of Chicago, a mother of three, a graduate of Grambling State University, with a degree in criminal justice. She is a fortunate survivor and now advocate of domestic violence and working through the issues that come through that. In life, her motto is, you can't be it if you can't see it, spoken in words from the anointing of Bishop T.D. Jakes. So at this time, we'd like to welcome up Ms. Simpson.
Good afternoon. For some of us, good morning, when we just got out the bed a few minutes ago. We're going to get through this anyhow. To my sisters, mothers, grandmothers in the room, daughters in the room, I greet you all in the name of Jesus. And I thank you all in advance for allowing me to come and speak a word of hopefully encouragement and empowerment to you all. I apologize in advance. Somebody told someone else that I talk, so I've been invited to speak somewhere else after I leave here, so I won't be able to stay to enjoy the program, but I know that you all will be planted with great seeds from knowledge and information, so bear with me. With my life motto that I go by, that's the title of this poem. It's called You Can't Be It If You Can't See It. Words spoken to me from an earthen vessel. Fear, guilt, shame, and defeat has always claimed a life for me. But he said, I can't be it until I see it. So what do I see? I see strength in the midst of pain, joy instead of sorrow. Mama said, sister said, and friend said. Even a doctor said, there's nothing left he could do. So what do I do at this point? What difference would change do? That's okay. Life has already beaten, battered, and scorned me. You can't be it if you can't see it. There goes that voice again. I see mountains moved in my life, peace in my house, healing in my body, my sons and daughters delivered from strongholds, my business sowing seeds for others to succeed. I see that I've been prepared for the race with tests, trials, and obstacles that I will face. I can't give up now, because my testimony will someday help you. You that have survived through the thorns in your side, husband left you, children acting crazy, depression, breast, lung, or cervical cancer, drug or alcohol addiction, HIV or STDs, whatever it is or was, declare it over and see it over. Let the devil know he no longer has a hold. There's gonna be days when you're gonna cry and want to give up. Don't. Press through one more time. You'll hear God say, my child, that battle is not yours, it's mine. My grace is sufficient. I've given you the vision. I know you see it. Don't let fear stop the plan I set for your life. Don't let your haters feed off your strife. I love them too and have plans to bless you and keep you. Today, woman, thou art loose. I created you second because sometimes I just like to save my best for last. Speak life into your situations and remember, you can't be it if you can't see it. Woman, be proud of who you are today. The shame from yesterday is over and far removed from you. Woman, we need you to survive. Our lives count on it. Woman, there may not be a cure in the natural realm, but my God told me to come by here today to tell you when 2 or 3 are gathered in his name, we can see a cure for breast cancer, cervical cancer, and the spiritual realm. Finally, woman of God, be blessed in all that you do and do in the lives of others. And remember, you can't be it unless you see it. Thank you.
Thank you so much. Those were wonderful and powerful and very inspiring words. Good afternoon, ladies and gentlemen who are here. My name is Dr. Dorian Miller. I'm the director of the Center for Community Health and Vitality, part of the Urban Health Initiative of the University of Chicago Medicine, and also a part of the Institute for Translational Medicine at University of Chicago, who are very happy to co-sponsor and produce these events of community grand rounds along with our incredible community partners. Thank you so much to Brandon Johnson from the Washington Park Consortium, who actually had the idea for doing our first community grand rounds for our 3rd season. This is the 3rd year that we've been doing this on breast and cervical cancer in support of the mothers, the daughters, the aunts, the grandmothers, all of the women that are in our lives. You know, oftentimes women think of themselves as being the supporters of other members of the family, that they are the people that support the sons and provide a platform of health and well-being. But oftentimes as women, we need to have support ourselves. And so having Brandon in his role on the Metropolitan Breast Cancer Task Force to say, no, as a man, I need to get behind this and to do this for the women in the community, I think is admirable. So just a little bit of congratulations to him for his vision for our first community grand rounds for this season. I also would like to mention and thank the incredible supporters that we have through our partnership with the Local Initiative Support Corporation of Chicago, the New Communities programs, and we've got wonderful leadership here of the people who have worked with us over the past 3 years and the production of community grand rounds. And so if the leadership could stand, please. South Chicago, QCDC is in the house, I know. We've got, who else is in the house? Woodlawn is in the house. Auburn Gresham. We also have partnership with Chicago Youth Programs as well, and also with Northwestern's Alliance for Research in Chicagoland Communities. This is the group that works with us in order to bring us the Community Grand Round series, and we're absolutely delighted to have an ongoing partnership with all of these organizations. I'd also like to bring your attention to many of the people that we have that are also helping to support this and to bring you information about your health and well-being who are here today, including Ms. Darlene Oliver, who's going to be one of our speakers here today, but she also has an information table in the back for her organization Beyond October. Dr. Angela Odoms-Young, who is also one of our speakers here today and has a table in the back from the University of Illinois at Chicago, and her work in the area of the connection of nutrition, obesity, and cancer, and also Miss Amy Shaw, who is here through another organization at UIC that's very interested in talking with particularly women who are here over the age of 65 about ways in which she can help you to stay healthier. And so again, information tables are at the back. Please stop by if you haven't done so already and to learn a little bit more about the information that's there. Without further ado, then, we're going to get started with our wonderful speakers for this afternoon. And the first person that we have on today is Ms. Heather Limper, who is a program coordinator for the outreach vaccination program that takes place at the University of Chicago. And remember, we're including the issue of breast and cervical cancer as a part of this program. And you may think that cancer is something that is inevitable. It's going to happen no matter what you do. But actually, Ms. Limper has some very important information on ways in which you can actually prevent cervical cancer. This is a very important information, particularly for our younger daughters who are in the audience, girls who are age 11 and up. And so please listen carefully, mothers, daughters, grandmothers, aunties who are in the audience, because she has some important information to share with you. Heather?
Well, I'd like to thank you for letting me be here today. That was a beautiful speech that we heard earlier, and I'm just happy to be a part of it. So full disclosure, I myself actually had cervical cancer when I was 18. So if you have any questions later on a personal level, I'm more than happy to talk to you. You can't hear me? Is this better? A little bit? Okay, so sorry, what I was saying is on a personal level, I had HPV and cervical cancer when I was 18. So if you have any questions afterwards on a personal note, and kind of the psychology that goes along with finding out that you have that diagnosis, or, you know, as a daughter, how do you talk to your parents, I'm happy to talk with you about that also. So today we're going to talk a little bit about cervical cancer and HPV. So when we hear about cervical cancer, most of us know it has something to do with sex, and we have to talk to our moms or daughters about it, and we can inevitably feel, this is our reaction, I don't want to talk about it, sex, gross. But HPV is actually a group of viruses that infect the skin. There are more than 100 types that infect the skin and 40 that affect just the genital region. And different types of HPV can cause warts, and in normal cells that turn into cancer. And so the cancerous versions of this virus are called high risk, and they can be known to cause cervical cancer, anal cancers, head and neck cancers, and throat cancers. And HPV is incredibly common. Approximately 20 million people right now have HPV. By age 50, 80% of all women will have acquired HPV, a genital infection. About 6.2 million Americans every year get HPV, a new infection, between age 14 and 44. The American Cancer Society estimates that about 10,000 new cases of cervical cancer in the United States are diagnosed, and about 3,700 women die every year from cervical cancer. Now, this is the United States. This is a global problem, but the reason we should care is because 3,700 deaths is equivalent to 8 747 jets crashing down every year and killing everyone in that plane. It's a huge problem. If we had jets like this crashing to the ground every year, people would be up in arms. What's going on? You know, why aren't we curing this? What's happening? But this is happening in our country. So how is HPV spread? It can infect anyone who's ever had any sexual encounter, even if it's not going all the way. So like we said, it's transmitted skin to skin. So any kind of sexual touching can actually transmit HPV. Some of the more high-risk strains can also cause head and neck cancers, and about 30% of mouth cancers are associated with HPV also. So even oral sex can put you at risk for HPV. It's not spread by the exchange of bodily fluid, so while condoms should always be used, they prevent pregnancy and any kind of infection that can be spread through bodily fluids, such as HIV, gonorrhea. They're not particularly going to help with HPV. And the reason is just that they don't cover the entire genital region on either sexual partner. So there's all of these parts of the genital that are still exposed, so any touching can still spread HPV. So you should always use condoms, but it may not help in this situation. So just a little bit, the cervix is made up of skin cells, and it's really just the bottom of the uterus inside of the vagina. And when you go to get a pap smear, this is what your physician will see if your cells start to become abnormal and cause cancer. These cancer cells are the little gross-looking ones around the opening. And so luckily, 80 to 90% of people who get HPV never have any symptoms, and it goes away naturally. Your body can fight it off just like a cold or any other virus. It's just these certain high-risk strains that put us at greater risk of developing cancer. And almost 99%, even greater than that, of cervical cancer is linked to HPV. So it's one of the first viruses that has been discovered to cause cancer. Some of the risk factors is if you have an infection with one of the high-risk types, early sexual debut. So the earlier that you begin having sex, the more exposure you're likely to have, and the greater your risk for HPV is. Also, the more sexual partners that you have, the greater the risk that you'll have a high-risk strain and get cervical cancer. Cigarette smoking has actually been known to really increase your risk for developing cervical cancer. Pretty much any disease is increased by smoking, so just don't smoke. Immunocompromised, pregnant women, HIV-infected women, you're at a higher risk for developing cervical cancer. And minority status. African American women are actually twice as likely to die from cervical cancer than Caucasian women. And the reason I think that this is a problem is the screening aspect of it. If you catch it soon, you can prevent it. But the longer that you harbor a virus, the more risk you're at for having cervical cancer. It can lie dormant in your system for 10 to 20 years before it actually turns into cancer. So if you're not having regular screenings, you might one day find out you have cervical cancer, even though you contracted HPV 20 years ago. So women who are older should still continue to get pap smears regularly. So the good news is that cervical cancer is preventable. If precancerous cell changes can be detected by a pap smear and treated early. Pap smears are done during a pelvic exam, and in the city of Chicago, there's an initiative where women can get free pap smears through the health department. There's also a vaccine for HPV that's highly effective and really safe. So with the HPV vaccine, all girls 9 to 26 years old can get the vaccine. It's recommended at the 11 to 12-year-old checkup. Also, all boys can get the vaccine as well. And like we said before, HPV can cause penile cancers and death from penile cancer. So it's really great to vaccinate both women and girls to protect girls and boys from it. There's two types of vaccine. The one that is covered by the city for free is called Gardasil, and it protects against 4 strains. So it'll cover and prevent most of the high-risk strains that cause cervical cancer, as well as some of the strains that cause genital warts. And it's also seen to protect against anal and vaginal cancers also. All right, so there's a vaccine, and we have pap smears. So why are all these 747s crashing to the ground and people dying, right? Because no one wants to talk about their 9 to 12-year-old getting a sexually transmitted disease-related shot. Every day in America, we have hundreds of kids who are dying from gun violence. About 135 children take a gun to school. 95 babies die each day. This is going on, and these are things we can't protect our kids against, right? But we can protect them against HPV and cervical cancer. And parents are the #1 source of information that adolescents get for sexual health. Teens say that parents most influence their decision about sex, love, and relationships. And it should be an ongoing discussion, not just a one-time talk, but a dialogue. This didn't turn out very well, but there was a mother who said a really great quote that saying, making sure that my daughter gets her vaccine before she has sex is one way I can help protect them their whole life. So the idea of giving it to a 9 to 11-year-old is you want to have the adolescent get their shot before they've had their first sexual debut. So if they've already had a sexual encounter, they can still get the vaccine. But if they've been exposed to a certain virus, it's not going to protect them from that one. So if you get them early, you can get their immune system primed to protect them from any of these viruses when they do start having sex. So it's a good thing to talk to them before you want to have this talk even, and acknowledging that 9 to 11-year-olds are the target audience. These vaccines are very safe, they're effective, and they're recommended. And if you have had a sexual encounter, you can still get one. I got mine, full disclosure. It hurts really bad, but it's really worth it to not get cervical cancer. The local health department, there's a thing called Vaccines for Children. So all children under the age of 18 are eligible for free vaccines that are recommended. So cost shouldn't be a barrier to getting everyone vaccinated. If you're Medicaid eligible, uninsured, or children who are underinsured, some insurances don't cover vaccines all the way, so you can go through the health department and they will give you the HPV vaccine. So some of the take-home points is that pap smears are necessary for everyone. Even if you've are no longer having regular sex. You want to make sure that it hasn't lying dormant and causing cancer. Pap smears can also be free through the health department. HPV vaccine can prevent cervical cancer. We want to get our girls and our boys vaccinated. And talking about sexual health and safe sex. If you're not talking about it, they'll find out, through the internet or some other source that might not be as informative and factual. So does anyone have any questions? I just raced through that. No? Okay.
Heather, thank you so much for that information. I actually think that because we're going to have some time for questions after all of the panelists, if you would just take a moment perhaps to make a note of your questions, and then we can come back to them after we've had the panelists to complete their presentations. Our next speaker is Dr. Angela Odoms-Young. Her biography is in the program that you have, but one of the things that we think is very important around the issue of the prevention of cancer is the role that nutrition and obesity plays in cancer, and this is a major area in which Dr. Odoms-Young does research. And there's also additional information at the table in the back regarding some of the work that she does. And so I have Dr. Odoms-Young to come up and talk to us a little bit about why does nutrition make a difference?
Thank you so much, and thanks for inviting me. I'm going to talk mostly about the basics, not about the barriers. Actually, much of our work is on the barriers, understanding how African American women specifically can be healthy. What kind of things, and I'm going to stand in my 15 minutes, but just what kind of things do you think African American women face when it comes to eating healthy and being healthy? You can just shout them out. Diabetes is one health condition that they face, but what kind of factors contribute to diabetes? Lack of time, not working out, exercise. We also have other stressors that keep us from being healthy. We care for kids. How many people have kids? Got to care for your kids. How many people work a job? So all of these things actually play a role when it comes to the issue of nutrition, obesity, and cancer. Nutrition is eating healthy. Obesity is maintaining a healthy weight. So recently there was a report that came out that showed excess body fat or being overweight causes approximately 103,000 cases of cancer in the U.S. every year. So about a third of the cancer cases are believed to be attributed to obesity. So when you look at the specific cancers, this is sort of hard to see, but there's been several cancers that have been associated with body fatness, or when we think about abdominal fatness. So when we think about either being what they talk about an apple, how many people have heard that? Are you an apple or are you a pear? So when we talk about abdominal fatness, so things like colorectal cancer has been associated with abdominal fatness, with overall body fatness, things like pancreatic cancer, postmenopausal breast cancer, endometrial cancer, kidney cancer. And so some of these things, when we think about cancer, we have to think prevention. My grandmother passed away from cancer. When we think about cancer, most of us think it is something that happens to us. We don't think about cancer prevention, and maintaining a healthy weight is a way that we can prevent cancer. So a healthy diet can help lower your risk of cancers. We talked about physical activity can help protect against cancer, and independently, physical activity is associated with a decreased risk of cancer, even beyond maintaining a healthy body weight. Higher body mass index or more weight and lower physical activity is associated specifically with a reduced risk of breast and colon cancer, as well as survival. So when we think on one hand about prevention is an issue, but after you get breast cancer, a lot of people are looking at maintaining a healthy weight related to breast cancer survivorship. So even after you get cancer and you get cancer treatment, maintaining a healthy weight is still very important. So a lot of people think after they have cancer that they don't need to be physically active, that there isn't a focus on being physically active or maintaining a healthy weight. And those types of behaviors can actually help improve your health and reduce your risk of reoccurrence. Current cancer therapies actually don't address obesity and sedentary lifestyles. Many people have been trying to advocate for that as a way for women to stay healthy even after diagnosis. So if you look at this graph that shows mortality from cancers according to BMI for U.S. women, and this is from a large research study. When you look at the type of cancer and the relative risk of death, you can see for certain cancers that the highest BMI category actually increases the risk of death. So things like pancreatic cancer, gallbladder cancer. So the take-home message is that overweight can actually increase your risk of cancer as well as you dying of cancer. So I know many of you probably wonder why. Why is weight related to cancer? A lot of us think that, we carry this excess weight. That tissue is actually active. We don't think about our fat tissue being active. But one reason that it's believed that overweight can cause cancer is because adipose tissue or fat tissue is an active endocrine organ. So the mechanisms by which fat can relate to cancer, there might be a relationship as far as the productions of things like estrogen. That fat is active, and that there's a belief that estrogen, so the production of certain sex hormones that by being overweight can contribute to cancer. Also, a lot of people are looking at the relationship between diabetes and cancer. So that the fat, we know that overweight can increase your risk of diabetes, but when we talk about insulin and insulin sensitivity and the production of insulin-like growth factors that play a role in diabetes can also play a role in cancer. Other hormones, as well as oxidative stress. And some people believe that when you have excess weight, you have this constant low-grade inflammation. How many people have heard of inflammation? So when you talk about this low-grade inflammation, that increase sort of stress on the body that can actually affect your immune system or your immune response. And some people believe that that explains the relationship between overweight and cancer. But most people don't think of obesity and cancer. What do they think about when you talk about risk factors for cancer that can play a role in prevention? What kind of things do you think about? Smoking. Most people think, and smoking is really important. But most people don't think about diet and they don't think about obesity. So this was a survey that was done in 2009, and it shows the percentage of Americans who believe that certain things are cause cancer or increase your risk for cancer. So 94% of those surveyed said tobacco causes cancer. Many people thought about cancer causing genes. And this directly shows that people are not thinking as much about prevention. They're thinking, if it's genetic, I'm going to get it. 87% mentioned exposure to the sun. 52% talked about diets rich in fruits and vegetables. Only 51% indicated obesity. And this is also a diet-related risk factor of cancer, for cancer, alcohol consumption, and only 46% related that to cancer. Over the years, even though we know more about the relationship between both diet and cancer, physical activity and cancer, and obesity and cancer, we really haven't seen that much change when it comes to people's awareness about this issue. So in 2001, only 35% of Americans thought that obesity was related to cancer. You do see some rise up to 2007, but from 2007 to 2009, even though we have a lot of research that has happened during that time, only 51%, as I mentioned before, of Americans believe that obesity is related to cancer. But most people are concerned about cancer. I'm sure all of you are concerned about cancer, the risk of cancer. Some studies show that people are more concerned about cancer than heart disease, diabetes, and stroke. And most people also feel that certain things like heart disease and stroke can be prevented, as I mentioned, but they don't feel that cancer can be prevented. Why is this a concern to you? African American women actually have the highest rates of obesity and overweight in the U.S. We know that, as some people talk about, this is a Eurocentric definition because we like our curves, but we want to make sure that we can maintain a healthy weight in our best body. I may not look like Halle Berry, but physical activity and eating healthy can help me maintain my best body. And when we think about from a population standpoint, even if we don't think we should be a BMI of 25, the fact that 78% of black women fall in the overweight category and about 50% fall into the obesity category. It's difficult to tell how fat your body fatness, unless you go get your body fatness tested, but we know that BMI can be an indicator of risk, both cancer risk, risk for other types of conditions. So we want to make sure that we can be in the best position possible, right? Right. So what did God say? That he wants us to live, right, and live more abundantly. So we want to make sure that we're in the best health. And so how do we do that? The American Cancer Society recommends that we try to balance our calorie intake, so what we eat, with our activity. And activity doesn't have to be going to the gym. It can be playing at the park with your kids. It can be dancing, stepping, line dancing, skating. It can be, a lot of people are focusing on church activity, like how people can get up in church and worship and celebrate, and how that can contribute to physical activity. You have to avoid excess weight gain throughout life. One of the problems is not that people are just heavy, they gain weight. And when black women are between about the ages of 40 and a little over 65, about 75, because after you get older, you start to lose weight, and that becomes a concern. But when you look at between about 50 and 65, those rates for black women actually are even higher than those at the younger ages. So you want to maintain your weight. If you just stayed at your same weight, then that helps reduce your risk, what they call weight maintenance. And even if you don't lose a pound, being physically active helps reduce your risk of chronic disease. So be physically active, at least 30 minutes of moderate or vigorous physical activity above your usual activities. And children, because we want to get our children started on the right foot, they need 60 minutes per day of activity. So sometimes when I'm at home and I want to tell my daughter to go sit down because she's too active, I know we've all been there. Remember that that activity can help our children. It can help reduce their long-term risk of cancer. Sometimes I want to sit down. I don't want to play this or do this or dance or play the Xbox, but those things actually can help. It's the small steps that can help reduce our risk of cancer. Eat healthy foods from plant sources, and also limit our calories. So things like soda, sugar-sweetened beverages. We want to eat at least 5 fruits and vegetables a day, and stay away from white bread, white pasta. Those are refined grains. We want to have whole grain bread, and limit your intake of processed meats. So I just wanted to end on this. When we think about eating fruits and vegetables, we can eat our colors. And we already know this as a people. What happens down south? How many people are from the south? Of families from the south? My family's from Mississippi. It was always vegetables on the table. We could take a little of that meat out, but it was always vegetables on the table. So when we think about red, we should eat our colors. And we can talk to our children about eat your colors. So lycopene, which has been associated with a decreased risk of certain cancers. So things like tomatoes and tomato sauce, pink grapefruit, watermelon, red and purple, berries, grapes, prunes, things like beta-carotene, orange. They give you, they're in things like carrots and mangoes and pumpkin. We want to eat our yellows, cantaloupe, peaches, oranges, spinach and avocado. There's a big focus now on eating dark leafy greens. And so they're finding that there's certain things in dark leafy greens that can be associated with a decreased risk of certain conditions. So I just want to leave you with 5 things. Move more, eat less, eat more fruits and vegetables, reduce your stress. That's a big thing. Reduce your stress. The last thing is there's a lot going on. We know that life is hectic. But sometimes you got to take time out for you. You got to think about you and your health. Because if you're not here, what's going to happen? So women, particularly women of color, carry a lot of balls. We keep this thing going. Right, ladies? Right. So we want to be here and we want to be healthy so we can ensure, and we want to also show our daughters that sometimes they need to take care of themselves. So thank you so much for having me. And I may not be able to stay until the end because my daughter has an activity, but I will make sure that you have my contact information. And so feel free to contact me. I'm at UIC in the nutrition department. Thank you so much.
Dr. Odoms-Young, thank you so much. So again, eat that rainbow, get out and get active, and make sure that you take care of your whole self, your physical self, your mental self, and also your spiritual self as well, in terms of your ability to reduce stress. Our next speaker for this afternoon is going to be Ms. Darlene Oliver. Her bio is in your programs, but she's here to represent not just the Metropolitan Breast Cancer Task Force, but a special program around breast cancer. Now, you may be wondering, okay, this is November, and aren't y'all a little late? I mean, wasn't Breast Cancer Month during the month of October? But it's very important to realize that this is an issue that we should be taking care of 24/7, 365. And so Ms. Oliver is going to talk a little bit about some of the efforts through the Metropolitan Chicago Breast Cancer Task Force and why they want to move beyond October.
Good afternoon, everybody. Come on, you can do better than that. Good afternoon, everybody. Thank you. So my name is Darlene Oliver, and I'm the Associate Director for the Metropolitan Chicago Breast Cancer Task Force. I looked at the agenda and it had on there that I'm the Executive Director. Not quite. That would have been, a nice little bump up, but no. I am the Associate Director. And today my presentation has two parts. The first is what I call the tale of woe, all of the bad statistics about breast cancer health disparities. But the second part of my presentation is what I like to call the tales of hope, because I'm going to be talking to you about what the Breast Cancer Task Force is doing to address all of the sad and dire statistics that I'm talking about in the first part of my presentation. So, our organization was started in 2006 after a study by the Sinai Urban Health Institute showed that African American women were dying from breast cancer at twice the rate compared to their white counterparts. So when this study came out, there was a big press conference and all of these institutions got together to try to figure out why that was happening. So we had individuals from institutions across the city come together to meet and determine the causes of that statistic and also to outline solutions. And what they determined was that there was a lack of access to quality mammogram screening and treatment for African American women in the city of Chicago, despite the fact that we're one of the largest metropolitan areas in the United States and have wonderful resources across the city. This chart is really interesting to me because if you take a look at it, it focuses on the differences in breast cancer death rates between black and white women when it comes to breast cancer. But if you look at the earlier part of that chart in the early 80s, there was very little disparity in breast cancer death rates between black women and white women. But as time went on, that disparity grew and grew and grew. And one of the things that's interesting about this chart is there have been so many medical advances in breast cancer screening and treatment. But for whatever reason, African American women, by the time we get to the latest data we have in 2007, have not been taking advantage of all of the advances that have occurred in breast cancer screening and treatment. So this latest study showed that the disparity between African American women and white women is 62%, which means that a black woman is 62% more likely to die from breast cancer than her white counterpart. That study also looked at the rates for New York City, for the United States, as compared to Chicago. Now, in New York City at the time of this study, the disparity rate was 27%. The nation as a whole was 41%. But here you go, we're doing the walk of shame. Chicago is at 62%. So women in Chicago are no different than those in New York, so it's not necessarily a genetic issue. The question is, what is going on in our wonderful city that's causing women to not get access to the care that they need and deserve? And I promise this is my last tale of woe, then we're going to get to some positive stuff. But this study was also interesting to me. It came out in April of 2012, and it was done by the director of the Sinai Urban Health Institute, the head of the Avon Foundation for Women, and then one of our staffers at the task force. And basically what they did was look at the 25 largest U.S. cities to see if there were similar disparities in breast cancer outcomes between African American women and white women. And sadly, what they found is that there's a huge disparity in 13 out of those 25 cities. The top 5 are Memphis, LA, Houston, Chicago, and I believe it was Milwaukee. I could be wrong on that last one. But Chicago is 5th on that list. So clearly we have a lot of work to do. So dun, 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 here's the tale of hope. What happens? What do we do to address all of these dire statistics? Well, at the task force, our mission is to end the racial, ethnic, and class disparity in breast cancer death rates within the city of Chicago, well, actually in the 6 counties as well. So how do we do that? Well, we engage in 3 different program areas. The first is research. We have a program that's called the Chicago Breast Cancer Quality Consortium. And the consortium works with area health providers, 80% of the area health providers that provide breast cancer screening and treatment within the city of Chicago to improve their quality of care. Well, what does that mean? That means that we're going into those providers and seeing if they're meeting national standards of care in finding cancer and treating cancer. And when we determine that there are issues, that they're not meeting those standards, we work with them to improve so that they can meet the standards that they should be meeting. And what I really love about the consortium is we're working with everybody. It's U of C, it's Northwestern, it's Cook County, it's St. Bernard Hospital, it's safety net institutions, community-based hospitals. We're trying to put everybody under this tent because our thinking is if we can raise the level of care that you get at any institution, then that's going to help women, and that's going to help us decrease the disparity that currently exists. Oh, and I also should give a shout out that this project recently went statewide, so we'll be able to help women throughout the state of Illinois by improving the quality of care that they receive. So in addition to our research, we also do public policy, and I'm so excited about this because we get to engage in advocacy. There's a program in Illinois called the Illinois Breast and Cervical Cancer Program that provides free mammogram screenings and treatment to uninsured women. Well, that program currently serves only about 10% of the women who are eligible to receive its services, which is utterly ridiculous. I mean, we know that there are fiscal problems in the state of Illinois, but we take the position that you can't balance the budget on the backs of people who really need the services. So we traveled ourselves down to Springfield in April of this year and spoke to the governor, spoke to 24 legislators about the Illinois Breast and Cervical Cancer Program and the need to try to keep more funding there. We knew going down to Springfield that there was an anticipated 4% cut in social programs across the board. We also knew that there was going to be an additional $3.3 million cut specifically for the Illinois Breast and Cervical Cancer Program. So we weren't happy about that, right? So we traveled down, and our advocacy efforts were very successful. Actually, this is an outreach slide. But our advocacy efforts were very successful. That 4% across the board cut did not happen to the program. Instead of getting a $3.3 million cut, that was reduced to $1.6 million. And while, you know, it would be fabulous to have more money put in that program, and that's our ultimate goal in this current climate, to have a program not be cut as significantly as was anticipated, we thought that was fabulous. And also, part of that is it's not just people in my office going down. It's women like the people that are in this room partnering up with us. We had 61 fierce women advocates go down there and talk to the governor and talk to legislators. So that was a really exciting outcome for us, especially since it was the first time that we had done a day of advocacy in Springfield. So the last thing we do that's related to this slide is community outreach and education. You know, there are often these fabulous conferences and meetings for health providers within the city of Chicago. And we just thought, why can't we have fabulousness for, you know, everyday folks? Why can't we have events for them and do it in a nice place and have nice food and music, but also tell them about breast cancer awareness and also link them to free services? And so that's what we did. This slide is from last summer where we had an event called Women Speak that was at the South Shore Cultural Center. When I say it was nice, it was nice. We had a really great turnout of about 200 or so women. We had a panel of experts, kind of like are up here today, and women had an opportunity to have their questions heard. So we just think reaching out into the community and passing on information is important, and that's part of the work that we do. Two other things that I would mention about our outreach and education. We have a program in the Englewood neighborhood that's called Screen to Live, and that is specifically for Englewood residents, and we link them to free services at St. Bernard Hospital and also the Chicago Department of Public Health. And this is for uninsured women who are 40 and over. And what I like about this program is, it's one thing to tell women about the importance of regular screening, but if you're sending them to a place that doesn't have the quality that they deserve, then you're really doing a disservice. So we are working with St. Bernard Hospital and CDPH to improve their quality of care as we're sending women to get free screenings there. The last thing I'll mention is Beyond October, which Dr. Miller referenced. So every year we have a big community event. And as staff, we sit around and we decide, what are we going to do this year? Because we want it to be fresh and innovative and something new. So this year, about 4 or 5 months ago, somebody said, we should have a mammogram screening day. And then somebody else said, no, we should have a mammogram screening month. And so we're getting all excited about that. And it should be not in October, because everybody's doing breast cancer events in October. And the reality is you need to have screenings done 365 days a year. Breast cancer does not take a break. Why should you? So our initiative is called Beyond October. And what we did was we had the goal of getting 500 free mammograms for uninsured women. And we wanted to have some of the better resourced hospitals provide that free care. So we have the University of Chicago, Rush University, UIC, Advocate Health. I'm forgetting some of them, but there's a whole, Northwestern. There's a whole list of hospitals that have agreed to donate mammograms for free. So after today's presentation, I'm going to be over at that table with the pink tablecloth, chomping at the bit to sign up women for this program. It's been really successful so far. Our goal was to get 500 free screenings. We have over 800 free screenings at institutions around the city of Chicago. So, I mean, it's a real testament to the fact that health providers really do want to help address health disparities in breast cancer. So I'm about to wrap up. We had our big kickoff event on November 1st at St. Benedict Church. 200 fabulous women showed up, and we signed up 75 women for free mammograms. So these are just some of the pictures from our kickoff. Thank you very much. I hope I ended on a high note after all of the bad statistics. Thank you for having me.
Ms. Oliver, thank you very much. I always think that it's wonderful to end on a high note, and I think one of these high notes that we can speak to is not only thinking about this from the perspective of people who are either doing advocacy or health delivery. We can think about it from the perspective of prevention, but also making sure that we understand that we have breast cancer and cervical cancer survivors who are in our midst that have the opportunity to share their story. And I'm going to introduce one of these people right now. Ms. Gail Briggs is going to come up and speak with us right now. She's a clinical director for community health working for the Healthcare Consortium of Illinois. She is a nurse by background and training, but she's also a breast cancer survivor and has a very personal story to share with you. Gail?
Thank you, Dr. Miller. Good afternoon, everyone. First of all, I want to thank Coppin and the University of Chicago for inviting me out to speak, and you guys for being here to listen. But I want to ask everyone a question in the audience. How many of you are breast cancer survivors? How many of you know someone who's had breast cancer and has survived? Very good, very good. Shout out to breast cancer survivors. Well, like Dr. Miller said, my name is Gail Briggs. I'm a nurse by trade. I work for the Healthcare Consortium of Illinois, which is a nonprofit organization in which we provide services or healthcare needs of people in the community through advocacy, awareness, and action. But I also, far most and most important, as you read in my bio, work for Sisters Working It Out, which we call SWIO. And SWIO actually come to community events like this, and we usually sign people up who need screening for breast cancer, pap smears, or what have you. And my sister SWIO from SWIO is here if you need assistance, if you haven't had a mammogram, or if you need a pap smear. She'll assist you when this is over. I'm here to tell my story, though. My story. In 2008, I was 47 years old, and I was diagnosed with breast cancer. Prior to that, a couple of years, I would say 2 or 3 years prior to that, they saw something, but they wanted to watch it. You know, we're going to just keep watching it. You know, everything's okay. Didn't have any problems, any issues. Did have a little pain, like a little shooting pain, but you know how we do, right? We ignore those things and keep moving. So I did. I had those pains, but nothing to, you know, get alarmed about. And I took a mammogram at a different location, somewhere else. And when I went there, they said, oh, we're going to do an ultrasound. I was like, ultrasound? You know how you used to go into the doctor, you get your report, you walk on out. They say, hold it, pump your brakes. we need you to sit down. And I said, for what? We need to do an ultrasound. I was like, oh my God, fear just came over. Ultrasound, what does that mean? So they did the ultrasound, and the technician, she was doing it, and I'm laying on the table, tears just rolling down my eyes. I'm thinking, oh my God, I can't believe I'm here. So at that point, they said, we're going to watch it. The doctor came in and talked to me. He said, we're going to watch it. It's nothing, you got really, cystic tissue, a lot of lumps, so I couldn't feel anything. So I said, okay. So the next year I went to get my mammogram, and so this doctor said, we're not going to watch it. I was like, really? They said, no, we get your films, we looked at it, we're going to go in and we're going to do a needle aspiration. So they took a little needle. I went, they said, come on in, it's an easy process. A needle's going to go into your breast, going to get a sample of your tissue, and we're going to check it out. So when I went there, I was panicky, frantic. It's like, okay, they're going to stick a needle in my breast. Is that going to hurt? And they was like, no, you're not going to feel a thing. I said, I don't believe you. Don't believe you. So I took my BFF with me. She's always encouraging, and she's always got something funny to say. So, she kept me going. When I heard those machines going, there go the tears flowing. I was like, oh my God, what are they going to do? They said it was just going to be a needle. It sounded like a saw. Oh my goodness. So, of course, she was with her jokingly self. Oh, you're going to be all right. You're going to be all right. Anyway, that was a breeze. I was like, oh, I could have did this. Oh, ain't nothing to that. So I did the needle biopsy. It came back. Everything was fine. No problem. They said, but you know what? Just to be on the safe side, we're going to take it out. I said, okay. So bring your family, come on down, go into surgery. We're going to take it out while you're on the table. We're going to look at it to make sure it's not cancerous. If it is, we're going to go back and, go into the margins and get what's left. I was like, okay, I can do that. So that went smoothly. Told my family everything was fine. We didn't find anything else. She's good to go. I'm like, a week off work? That was easy. So I went back to the doctor. Of course, I stayed off week. I had to go to the doctor to get a return to work statement. And so when he examined me, he said, okay. He said, how you doing? I said, I'm great. I was just happy. I had it was nice outside. I had a whole week off, no pain, no problems. So he said, oh, okay, good. I'm glad you're doing well. Good. So he said, have a seat. I sat down. He opened up my folder. Let's see what's going on here. He said, oh, you have cancer. I said, excuse me? He said, you have cancer. And I was alone. I had no one there. So that's the first thing I'm going to tell you. If you have a diagnosis or something going on, take somebody with you to advocate for you, because at that point, you don't hear nothing. All I heard was, you got cancer. I was like, I got cancer. And so he started telling me something. I didn't hear nothing. I'm just shaking my head. Really? Okay. Like I'm really listening, but Lord knows I didn't hear him. So he finally stops and he says, okay, go ahead. I said, what? You can cry. Oh my, I just bawled. I was out of control. The nurse came out saying, we do need this room. Can you, doctor, can you get her out of there? I couldn't stop at that point. I was like, oh my God, what am I going to do? So I think he had said at that point that I'm going to see a radiologist or something like that. So I was like, okay. So he said, someone will be in touch with you. I said, okay, fine. So I left there. I got in my car alone. And I'm driving down the street on the highway, and I called my BFF. I said, I need to come see you. She said, what's wrong? I said, I got something to tell you. So I get to her house. The first thing I did was start bawling. How do I tell my kids? At that time, I was divorced. And as you see in the program, that is my husband. We have a very good relationship. He's not my husband anymore. He was my husband, so he's my husband. And I got that from a friend of mine. She started husband, and I'm carrying it on. But she said, call him, and sit down and talk to him and tell him what's going on, and you all can sit down and tell the children together. And I said, you're right. I said, do I have to tell them? Because the first thing, you don't want your children to be hurt. You don't want to cause no harm, no heartache, especially to them. So I was like, okay, you're right. I'll do that. So I did. My kids were fine with it. At least they appeared to be fine. They were okay with it. So we did what we had to do. We went through treatment. I went to work every day. Treatment was radiation Monday through Friday. 8 o'clock in the morning, I was a half an hour late for work. They understood at that point that it was okay. And, you know, it was okay in the beginning. I kept strong. You know, you got to stand and be encouraged and hold on and be strong. And I was strong all the way, but them days started getting to the end, and I started slowing down. I was getting tired. And then one of my bosses came in and said, "Can you make up that hour?" I said, "Really? I can hardly stay awake now. And you asking me to make up an hour?" I said, "No, I don't think I can do that." So I finished my treatment, and shortly after I finished the radiation, I got terminated from my job. So I went to the radiologist and I said, I can't afford Cobra, because we know how expensive that is, right? Can't afford Cobra, so I won't have any insurance. So she says, "Well, if anything happens, then just go to the emergency room and they'll take care of you." If anything happens, go to the emergency room? Do you understand what I just went through? So she was like, "You'll be okay, Miss Briggs." So I'm like, "Okay, fine. So, of course, then I shut down. You get discouraged, and you do whatever it is you have to do. Fortunately, I have a friend who I used to work with when I did hospice, and she was a physician. And she was just calling and check, "Hey, Gail, how you doing?" Blah, blah, blah. I said, "I'm fine." I said, "I need a prescription of my blood pressure medicine running out, and I need some more tamoxifen." And she was like, "Well, you need to come see me. You ain't seen no doctor?" I said, "No, I ain't got no insurance." So she said, "Come see me." So I went to see her, and she told me about this program, Illinois Breast and Cervical Cancer Program. I was like, wow. I said, "And they're going to help take care of me?" She said, "Yes, they will." She said, "You go over there to Mercy Hospital, they'll give you a medical card in 2 days, and you go back and follow up with your oncologist." I thought that was awesome. So here I am today, 4-year survivor. I've had a couple of other, I'm employed now, so I'm not on the program anymore. I had to start paying for my prescription, but it's all good. It was there for me when I needed it. And what I want to say to you all, sometimes you're down or you have a job or don't have a job, and you feel like, "I can't get it done because I don't have any insurance." If you know anybody in your family, anybody in your circle, any of your friends who don't have insurance and they need this done, they need to go to Mercy, for one. I know for sure Mercy still has the program. And I believe Metropolitan Task Force has a site online that's low cost and no insurance. They give you different locations. Access is one, and it's a couple of other ones. So absolutely. And our panelists here, Dr. Odom, she is so right when she talk about nutrition. Since I not had breast cancer, I've been to boot camp, I've been to yoga, I've been to Zumba, I've been to, you name it, I've been doing it. I've been trying real hard. And nutrition, when I had my personal trainer, she was like, "You gotta eat right." I said, "Okay, how do I do that?" "You gotta eat 3 or 4 times a day." I said, "Are you kidding? I ain't got time to eat like that." "Well, what do you plan on eating for lunch?" I said, "We just got up for breakfast. What do you mean lunch?" "Well, what do you eat for dinner?" She said, "Plan out your meals." So the things that she just told you about as far as nutrition, you just have to be creative with it. I know it's hard for us to change our habits, but you have to. And me, I don't want to go back, no reoccurrences. Trust me, I do not. I got 1 more year for tamoxifen, and I'm almost scared because that's my protection right now. So, but I make sure that I try to eat the correct things. You know, we had this little thing going at work where we all making these old smoothies with the NutriBullet. You know, putting your spinach and your vegetables and your fruits, everything in the thing at the same time. That way, it won't be hard to look at on your plate and stuff it in your mouth. You just drink it on down, and it works. But I want you all to please be encouraged. Again, if you have to go to the doctor, take somebody with you. And if you need assistance with making your appointment for a follow-up exam or a breast screening, see Angela here. She'll help you with that. Or if you have a friend or family member that needs help, she'll give you her card so she can assist them as well, okay? Thank you.
Thank you so much, Ms. Briggs. I think that those were wonderful words of encouragement, very practical information in terms of what's needed, and also for women who don't have resources, don't let your lack of health insurance be a barrier. Now, I understand that Dr. Olapati has arrived, but also Reverend Barbara Wilson from Coppin AME Memorial Church is here as well. Reverend Wilson, you want to put your hand up here and say hello? Thank you so much. After Dr. Olapati finishes, if you could just give us a couple of words, please, we would really appreciate it. I'd like to introduce my wonderful colleague, Dr. Funmi Olapade, who's a professor of medicine and human genetics at the University of Chicago, who has some very interesting information to share with you, particularly around breast cancer and some of the genetic factors around breast cancer and what we're seeing in African American women. Dr. Olapade's distinguished biography is in your programs, and she's bringing up a few slides right now that she's going to be sharing with you. But please give her a welcome, warm round of applause, because she's having a very busy day today, but wanted to make sure that she came today and shared information with us around breast cancer genetics.
It's really a pleasure to be here, and I think it's been a while since we came back to talk about some of the work we've been doing in genetics with the community. So I thought this was a really good time to tell you about what we know and why it's important to get the community involved in some of the genetics research that's going on. So how many of you have heard about the research on the genes that cause cancer or the causes of cancer? How many of you? How many of you have heard about the Human Genome Project, where we're trying to find out all the genes that are causing cancer, causing diabetes, causing high blood pressure, any of that? Have you heard about it? No. Okay. Nobody has ever heard of the Human Genome Project, other than how many of you have heard about the Human Genome Project? You heard about it. Okay. All right. So in 1995, we started a project to find out all the genes that can possibly be in a human being, okay? And we wanted to know how these genes work to cause cancer and all different diseases. So the scientific community came together, okay? And we went, because before 1995, we used to do research one gene at a time, okay? Before 1980s, we used to do research only on men. And then women got together and said, let's study women as well, right? So a lot of the ways that we did research has been evolving, okay? So now, the type of research we do is what we call team science, where you get teams together. So in 1995, they decided, let's get all teams together and do the Human Genome Project. And that project was budgeted for $5 billion. And only a few of you have heard of it. It's like sending a man to the moon for the scientific community, right? Because we, at that time, thought if we could just know or how all the genes are wired, then we would be able to know how diseases start. Because you are born with your DNA, right? Everybody knows about DNA, right? You get your genes from your dad, and you get from your mom, and then, then it makes you, and then a lot of other things. So at the time that we started talking to people in the community, it was because we knew that the Genome Project was going to impact all of us one way or the other, and that we had not really figured out how it's going to impact us and what we're going to do about it, right? And it looks as if, since many of you don't still know about it, that we haven't really been having the conversation we should be having about it. So that's why I thought I should come back and let's readdress it, okay? All right. So when it comes to breast cancer, when we start talking about people and populations, how many of you know that, at least scientific literature, I'm originally from Nigeria, And before I even came to this country, what I know in my oral mythology is that life began in Ile-Ife, right? That the life started in Africa, right? So you will all accept that. Okay. So if life started in Africa, it means that people came out of Africa and they went all over the world. Okay? And then there's some people who came later, which is what happened during the slave trade, which other people came out of Africa later than the original migration out of Africa. You understand that? Okay. So when we start looking at who is getting breast cancer, what's going on around the world, what you will see is that in those areas where you have red, right? And then you see all of China, you see a lot of Latin America, you see that they're in different colors, right? So Europe, North America, and Australia is where you have the highest rate of breast cancer, right? So anytime we see a geographic pattern where it looks as if some people get it and some don't get it, we're always wondering why, right? So all the arguments and all the things that people have been talking about, so some people will say that you need to eat tofu because Asians don't get breast cancer. Right? We don't know why Asians don't get breast cancer, but it may not be because of tofu. And it's the same thing. People will tell you, well, African Americans have obesity. So as a result of that, that's what causes everything. Right? So what I'm trying to tell you is that there's so much we don't know. And that's why it's really, really important for the community to begin to ask questions about where is the research and how does the research benefit us? Are you following me? Okay, so when I started coming to the community and we started having this conversation, it's because I know what's going on. I know where the research is going. I know a lot of the money that's being poured in. I told you we used $5 billion to do the genome project. After we did it, we then realized that, oh, by the way, it's not just one genome. Everybody has their own genome, right? Because even though you have your own DNA, even twins that are born and are identical, when you look at them, their life story is not always the same, right? Because other things happen to them. So that's why we started asking ourselves, it's not just the genes that matter, it's a lot more than the genes, right? And that when we begin to do genetic research and we start using genetics to help people get better, well, we better make sure we understand what's going on in all populations. And since, majority of you in this room don't even know about the Genome Project, it means we haven't done a good job, right, of explaining and bringing everybody up to speed. We should be teaching genetics in our schools. Everybody should be engaged in one way or the other, thinking about how all of these things impact health. Because if you look at the reasons why we're so concerned about breast cancer in the community, prostate cancer in the community, is that there's a lot of stigma still attached to cancer, right? You don't want to hear it. You don't want to do anything about it. In Nigeria, which is where I come from, people will say, I reject it in Jesus' name. Okay? And as a result of that, even when people can come in and have their problem taken care of right away, they're praying about it or they're saying, I don't want to accept it. Okay? And the thing is, I can tell you, for a lot of my patients, they're not different from my brothers and sisters in Nigeria, because it's like, I'm going to pray about it, I ain't going to worry about it, right? And so I'm always saying that, well, science and technology allows us to have a little bit more information than just, yes, we leave everything in God's hands, but God is also giving us wisdom, intellect, knowledge, and that knowledge is what we have to keep advancing to improve health outcomes. But the stories are not really good. What? If you look at some of the reasons why all of those places are still not having a lot of breast cancer is because women are dying of other things. They're dying during childbirth. They're dying from gunshot wounds. They're dying from accidents, right? And then the few that live, right, they're dying from breast cancer without even knowing that they have a risk for breast cancer. And that's the same thing that's going on sometimes in our city. This is, you may not see this very well out there, but what I'm showing up here is that if you look at cancer mortality from 1950 to 2007, and I wanted to use the United Kingdom, okay, UK, that's people who live in London. I wanted to use that example because they don't have a problem with insurance. They have universal national insurance. It doesn't matter whether you're poor, black, or white. If you live in the United Kingdom, you will have access to health care. Okay? I'm hoping that this is part of the things that we have to think about in this country now, of how we get everybody, so that it's not that I don't have a doctor that will prevent you from going to make sure things are checked out. So when you have doctors in the community, and part of what the Southside Collaborative has been doing is to make sure that everybody has access to a primary care doctor closer to their home. When I first got to this country, because it was easier to go to Europe than to come to America, one of the things that was always a surprise for me was at Cook County Hospital, how long it took for some of my patients to come from 211th Street, right? And the nearest hospital to them is Cook County Hospital, right? That is sacrilegious, right? Or they would say, well, even all the hospitals that are closer to me, I don't trust them, so I only come to county hospital. So we need to do something about improving the quality of everything in our neighborhood so that we can trust them and we can make sure that if somebody has a problem, there's a doctor around that can actually take care of it. Or there's a community health worker or somebody that can help you figure out what's going on. And I mean this because unless you have primary care, then it's really hard to get to the experts, to get to the specialists. And one of the things that I'm hoping that our big new hospital is going to try to do is to have partnerships with primary care doctors all across the South Side, so that when somebody has a problem, okay, they won't have to wait looking for a doctor, looking for a place to go. So that's why, if you look at what's happened in the UK, breast cancer was going up and up and up. And then by 1980, they've dropped it significantly. You can see that drop in that first graph, right? People are no longer dying from breast cancer if they get diagnosed early, if they get screened, and if they take their medication, right? Now, look at lung cancer, okay? Lung cancer was also going up. And why was it going up in women? Because women wanted to become like the Marlboro Man. Right? The Marlboro Man, right? And so instead of saying, okay, we have arrived, we can vote now, what women started doing was they started smoking. Okay? And do you know that smoking kills more women now in this country than breast cancer? So for all those girls and all those people who are trying to smoke in the community, I don't know what we're going to do about that in the community, but if you just took away tobacco, all cancer deaths will reduce 30% just by not having any tobacco around. Okay, so when I'm talking about women's health and I'm talking about breast cancer, I always have to talk about tobacco, because I see when I'm on service in the hospital, I see more black women coming in with lung cancer than I see with breast cancer. Did you know that? So anyone that you know that's still smoking, go and talk to them about quitting. Because if you actually quit, you start decreasing your risk of dying from lung cancer. So having said that, look at colorectal cancer, all of that. You can see everything is going down. Uterine cancer, stomach cancer, cervical cancer, everything is going down. And why is it all going down? Because we know how to prevent them, right? How many of you have heard about HPV vaccine, getting vaccination, getting your pap smear? That's the reason why people are no longer dying from those cancers. Unfortunately, breast cancer is still very high, and that's why we need to do something about it. This is another graph that I want you to look at. So you are not doctors, you don't need to worry about the details of this, but this is people participating in a clinical trial. You've heard about clinical research, right? Participating in a clinical trial. Every time the results come out, they say racial differences in breast cancer survival. White women do well, black women don't do well. You go to the army, everybody gets equal access. White women do well, black women don't do well. And the question is, what's going on? Does anybody have any ideas of why that may be the case? Pardon? What you're eating, okay? What else might be the case? Where you live, okay? Yeah, not having regular checkup. Actually, one of the things that we found when we did a study in the University of Chicago is the farther you live, the better you do, right? Because all those people who have knowledge, who are really active, they find the best doctor, they don't mind driving, they just want to get the best care, so they come down here, okay? And then the people who are in our neighborhood, right, you see them, they missed appointments. They didn't show up for their doctor's appointment. They were supposed to come and get their medication. They didn't show up. Now, we don't know why they don't show up, but part of why they don't show up, maybe they're too busy. They have no, we don't know why they don't show up, but we know they don't show up. Right? So how many of you have missed your doctor's appointment because you forgot? Okay? So it's okay to forget, but then to forget and not do anything about it. So as soon as a black woman, many women in our program, as soon as they finished getting their treatment for cancer, it's like, I'm done. I don't want to come back again. I don't want to do this. I've been healed. And I talk to them, no, you have to take this pill, tamoxifen, you have to take it for 5 years. No, you have to do this. And they don't do it. So we see it as, they will say it's racial differences, but you're all right. It's what you eat, it's what you do, it's how you exercise, it's whether you get up and say, I'm a cancer survivor and I'm going to survive, right? Or you're going to say, oh, I've had cancer, I'm so depressed, I don't even want to go out anymore. We see all sorts of reaction, right? So the reason why I'm bringing this back is that everybody is talking about black-white differences. And I'm saying maybe it's not just black-white differences, because I also see many black women who are super conscientious. They come, they exercise, they eat right, they want to survive. So it's not black or white thing, right? Sometimes it's just behavior or even just ignorance, just not knowing, right? So not knowing is the reason why we've got to share information, right? You've got to encourage one another. There's a whole literature now on social networks where, depending on, if everybody in your network is fat, you're all going to be fat, right? If everybody is exercising, feeling positive, then you're all going to be feeling positive. So what we need to do is we need to encourage one another, right? It's not about, well, I'm only going to hang out with people who look like me. We've all got to keep supporting one another and helping each other get better. Okay? So if you know a cancer survivor who hasn't gone to see their doctor, if you know somebody who is challenged and because of that they can't exercise or eat right, let's as a community figure out a way to support them. You understand? Because even sometimes when people talk about your weight and obesity, it's not whether you lose weight or not. It's really just about, are you active? Are you getting yourself up and down? Are you engaged? Are you sharpening your mind? So I don't talk about weight anymore. I just talk about, are you active? Are you thinking? Are you moving? Right? Because that's all we need to do, is just keep moving. and being part of the action. Okay? So how are we part of the action? So one of the things that our results has, the work we're doing has shown us is that breast cancer is actually not one disease. It's different kinds of diseases. And it affects people differently. Did you know that before? Right? Okay. People have been talking about triple negative breast cancer. This is the type of breast cancer that we see a lot in black women. But we also see the ER positive breast cancer in black women. So we see different types of breast cancers in different types of black women. So every time you hear that, oh, black women get aggressive breast cancer and this and that, sometimes it can be really a negative, right? And then you get scared and you don't want to do something about it. It actually turns out that if you pick ER negative breast cancer early, it's actually the most curable. What did I say? It's the most curable. Because ER positive breast cancer can relapse 20 years later. ER negative, triple negative breast cancer, if you respond to treatment, that's it. Okay? The challenge is that by the time a lot of women come, so typically in the California Cancer Registry, African American, Hispanic women, we went to Nigeria. These women, by the time they finally make it to the doctors, it's so advanced that we can't cure it. So we keep saying it's aggressive, it doesn't respond to therapy. So that's why it's really very important for us to begin to think about, Can somebody come and help with the AV? Did it just shut off on its own? It's coming? So anyway, so that's why I want to make sure that we understand what we're talking about. That yes, breast cancer is not one disease. Yes, treatments may differ, but it's not about, black women only getting aggressive breast cancer and then everybody getting scared about even talking about it. There are different types. So one of the things that we've been doing, and what I wanted to share with you, is we actually have now been doing a lot of genetics research to really look at what are the genes that cause triple negative breast cancer, what are the genes that cause ER positive breast cancer, what are the genes that cause HER2 positive breast cancer. And now, because of the Genome Project, we know so much about that in white women. Okay? Why do we know so much about it in white women? Because remember, the genome is going to be first known about all those red areas that I told you. Red in North America, red in Europe, red in Australia, right? And then women in Asia, women of African ancestry, Hispanic women. Remember, you saw that map, right? They're not the ones that have been involved in this research. I mean, that's just what's going on. Okay? Now, when you have that type of research, when we started our work in Chicago, this was in 1992 that I started our cancer risk clinic. It was because we were part of the research to find breast cancer genes. And the first breast cancer gene we found was the BRCA1 gene, right? How many of you have heard about BRCA1? No, you cannot tell me you have not heard about BRCA1. Okay. All right. So it turns out that when you are looking for all the risk factors for breast cancer, okay, the most important risk factor for breast cancer is, because you're a woman, right? The most important risk factor for prostate cancer is you're a man, right? So those are the two things. And as men get older, they get prostate cancer. As women get older, they get breast cancer. Okay? That's why female gender, age, those are the two things. Part of the reason why cancer is increasing is because there's a link between getting older and getting cancer. Okay? We all want to get older, and that's why we're going back to the drawing board to say, what are the things that you get exposed to all through your life that increases that risk as you get older? And what can you do to prevent it, right? And then there's some people who, the cancer runs in their family because they all smoked. So the Genome Project allowed us to find, they were looking for genes that cause lung cancer. Guess what they found? Genes that cause addiction to tobacco. All right? So, some people smoke and then they want to quit, they can just quit just like that. Some people smoke, they can't quit because they're addicted to it. And it turns out that if they're addicted to it, they smoke more tobacco, they get a higher risk for lung cancer. You can see how the genes can sometimes work, right? So we started looking for family history and saying, okay, if in fact family history can be a risk factor for breast cancer, that's how we found the first African American family that I took care of. And this woman ended up dying from breast and ovarian cancer. And her mother died from breast cancer twice. She had breast cancer. And that was why in 1997, we've been doing this research since 1997. We've been going around saying this is not only Jewish women who get BRCA1 or BRCA2 mutation. Women in our community also have it. And we need to make sure that they have access. We actually got the one good thing that Governor Blagojevich did was allowing Illinois IDPH to pay for genetic testing for women who need it, right? Because by knowing, you can tell your family members that, oh, we have this gene, we better go and get checked up. Guess what's happening? In my program, even though we're seeing black, we're seeing white, when I see the white families, oh yes, I'm going to tell all my family members. Oh yes, they're all coming. They come from all over to come and see us. And I'm begging my sisters, can you tell your sister to come? Can you tell your brother about this? Can we help you write letters to them? And it's like, well, I don't think they want to be bothered about it. Okay, why do you think that's the case? Pat? Stereotype? What else? Fear? Fear? Yeah. Yeah. So we actually did research and found out that it's true. If somebody tells you you're going to get, you have a risk for cancer, the first thing is you're going to be afraid. You're going to be worried about it. And it's like, we don't have time to worry about something else. We did a study. We went to county and we said, oh, there's a pill you can take to lower your risk for breast cancer. And when we asked our sisters, oh, no, we ain't into that yet. Okay? Well, they're not into that yet. But, everybody's into those high heels. You're into the fashion. I mean, you're getting it everywhere, right? But you're not into the science that actually makes you live healthier, better. Why is that? Okay, so I just wanted to let you know that's what I'm seeing, right? And so this woman, the same white family, I told them the same news. This woman went and said, oh, you know what? I don't need my ovaries. I'm getting it out. My African American patient said, God can't be that bad. I've survived 2 cancers. I'm going to pray about it. And then 3 years later, she had ovarian cancer and she passed from it. So we need to figure out how we talk about these things and how we get people to actually do the things that will lower their risk for cancer. So these are things that I'm saying. And, we've got where the genome, because of, we thought we had one genome. Now we're actually doing a big project to get the genomes of people of African ancestry, to do all sorts of research. That's the beginning research that we're doing, because we've gone from doing one gene at a time to doing all of the genome, okay? So we're going to be doing that research at the University of Chicago. And I'm frustrated that we're not getting the benefit to the community. So how do we get that benefit to the community? What do we have to do to get the word out, to say genetics is not everything, but it can at least tell you, so how many of you have had your cholesterol measured? Okay? if it's high, do you take medication to lower it? And you know you should lower it. And you try to lower it. Okay, so why can't we measure something and try to lower cancer risk? So that's what I wanted to come and talk to you about. Okay, and maybe you can give us some ideas, because when we've gone on now, we're doing work in Ibadan, and this is the kind of breast cancer they're still seeing in Africa. Okay, and I can tell you that occasionally we see cancers like this walk into our emergency room from the south side of Chicago. Okay, this is no joke. Okay, we're finding out what are the risk factors for breast cancer. We're finding that if you breastfeed, right, and you take your baby and you nurture your baby, you put the baby on your back, right, and you don't have premature birth, all of those things later on impact whether you are obese, what happens to you. So what we're finding is that the mother-child bonding, right, is so important. And all over the world, they're telling women to breastfeed. In America, do you know the average number of months that African Americans breastfeed? 2 months throughout their whole life. They leave the hospital, they get the baby bottle, and that's it. And yet, the nurturing, just putting the baby to your side and breastfeeding, right? The closeness that when you hold a baby in your hand and nurse them, not only does it lower blood pressure for women, it lowers breast cancer risk, it prevents you from keeping on the weight after you are pregnant, and nobody is saying that in our communities to young women who are giving birth. Okay, so I gave you one charge first. Help people in your community to move to keep moving, right? Support each other to move. The second thing I want to say is, if you know anyone who's had a baby, it's not easy to breastfeed, but breastfeeding is probably the most important thing that young women can do to lower the risk for breast cancer. We need to support them. People are having policies, they're doing that. But the reason why sometimes these girls and these young women can't do it is because grandmothers used to help you when you have a new baby. But now all those social structures are gone. Nobody has time for anybody else. Right? I remember when I had my first baby, my first year in this country, in 10 days my nipple was cracked. And I was like, don't let that baby come near me, because it was so painful. Thank God I went home for Christmas, and as soon as I got there, everybody took the baby from me, and they were like, you sleep, you're not going to get up, just sleep. And all you have to do is pump the milk. And before I knew it, the cracked nipple was gone, and I was able to nurse for more time. So I see the challenges that by us all being too busy, we can't really take care of so many things that we need to take care of. Am I almost done? Because I can keep going on and on and on, but I think I'll stop there.
Dr. Olapati, thank you for some of those wonderful comments, not just about the science of breast cancer, but also about issues of prevention, the importance of, if you have breast cancer and you're diagnosed, figuring out whether or not there might be a hereditary component, because one of the things that's very important to us in our communities is that it's not just a question of us, but it's a question about taking care of the generations to come. So if you could turn the lights on in the back so that we can see our incredible panel that we've had here today. Thank Dr. Olapati, Ms. Briggs, Ms. Oliver, and Ms. Limper. Dr. Odom Young had to leave, but I want to remind you of a couple of things, and we're going to get to some questions in just a moment, because I know many of you have some questions for our speakers. We are going to have evaluation forms that are available for today. I believe the young lady is passing them out right now, and so please, we want to get your feedback about the event that we've had today. Tell us what works, tell us what kinds of things we can do better in order to work on this on the Community Grand Rounds project. And also make sure that you stop at the back of the room before you go, because we'll also have some parting gifts for you as well. But without further ado, please, any questions that we might have from the audience for any of our panelists? So, young lady in pink here, yes. Olapade?
No. So that study, what we were actually looking at was, we looked at women who breastfed versus women who didn't breastfeed, and we looked at women who were younger than 40 or older than 40. Okay, and what we found was that for every year that you breastfed, okay, you decrease your risk for breast cancer. Okay, and over the generation, women, so my mother had 6 children, and over her lifetime, she probably breastfed for more than 120 months total, just counting for each child how many years she breastfed. So for the women who breastfed the longest, okay, compared to women who breastfed the shortest, there was almost a 36% difference in the cancer risk, where women who breastfed the shortest had a higher risk than women who breastfed for a long period of time. Okay?
Thank you. We had a question in the back here. So the question of environmental toxins and radiation and how they might impact breast cancer.
So there's a lot of work to be done still in terms of what are the things in the environment that increase breast cancer risk. But one of the things that we know is that women who were in Japan when they dropped the atomic bomb, depending on when you had that excessive radiation exposure, it increases your risk for breast cancer. Women who were treated for other diseases but then had their breast radiated when they were younger, they had an increase for breast cancer. Now, it doesn't mean that if you have breast cancer and you get radiation for treatment of your breast cancer, that's going to increase your risk. It's just over your lifetime, if you have excessive radiation exposure to your breast, then it can increase the risk.
Other questions for our panelists? My goodness, we have a very quiet audience this afternoon. Filling out the evaluation forms? Okay. We have a follow-on question here. Yes, the lady in pink in the hat, yes. So the question of getting pap smears after a hysterectomy, it depends upon whether or not the cervix is in place. Oftentimes when hysterectomies were done, particularly in the 60s and 70s and even the early 80s, that the upper part of the uterus was removed, but the cervix was actually left intact. And so given that that's the source of cervical cancer, usually not. There are some types of cervical and vaginal cancers that are associated with particular kinds of hormones that were given in the 50s and 60s, for whom those women, even after having had a hysterectomy, should still continue to get pap smears of the vaginal area. But it's a risk factor that you really should talk to your doctor about.
Actually, talking to your doctor. So one of the things that I wanted to share with you is these days we in the medical center, we're faced with challenges of sharing information, right? So when you are an investigator, you do research, and so I do genetic research, and I have all this information, and the information can be helpful to patients and it can be helpful to their doctors. But we've been really having a debate about how do we form a network of people who are working collaboratively so they can find cures for cancer, so that we're not waiting, every research that is done in white women, I can tell you, it takes at least a decade before we get enough information to know what to do with black women or Hispanic women. And so all during that time, we'll keep saying, well, the rates are high. There's disparity, right? Because the studies are going to be done first in Boston, right? And then from Boston to New York to San Francisco. And I just wonder whether we shouldn't really be thinking about how we form networks, right? Where we can share information that is pertinent to women of other ethnic backgrounds, because that information can really be very important to the healthcare.
You know, Dr. Olopati, you showed a slide a little while ago which showed the migration of people from the continent of Africa and migration patterns all over the world. But one of the things that I think we need to keep in mind is that as people of African descent and part of the African diaspora, we have the widest variation in terms of our heredity of any other group in the world, because every other group in the world came from Africa and came from us. And so the opportunity to think about ways in which, by participating in the kinds of research studies that Dr. Olopati mentioned, that we can learn more, not about just ourselves or helping our family, but how we fit into the larger world. And so I think being able to help to make those contributions to improve the health of our people is very, very important. I'm going to give some of the other panelists the opportunity to make some comments as well.
I just wanted to make one announcement and just remind people that I will be in the back signing up women for free mammograms. If you're 40 or older and uninsured, I have appointments available at the University of Chicago. So don't let me leave here without signing some people up.
Okay, and we have another announcement in the back. Yes.
Sure. Even if you have a long-term partner, as we said before, it can lie dormant in your system. So I would still recommend that you get your pap smear every year, because you might not know. And as horrible as it would be, even if you're in a monogamous relationship, you don't know how loyal your partner is. Even if you do know, it's just good to still get checked.
Dr. Miller, I just wanted to add to what you were saying as far as clinical trials. It's very important that we participate as African American women and men in clinical trials. I know we all have this myth that the Tuskegee Institute, they're still going to do something with our information, but believe you me, we are protected. Anytime they do some type of study, everyone has to go through a process where they are educated so they cannot use your information for any abusive situations at all. So please, get rid of that myth and participate in clinical trials.
Thanks so much, Ms. Briggs. And the other thing that I wanted to say is that for people who have an existing medical condition, because of Obamacare and the Affordable Care Act, they cannot discriminate against you. You are insurable, and that's something that is a tremendous victory for people who have any sort of, not just any sort of cancer, but diabetes or other conditions. Don't make that a barrier to applying and getting health insurance coverage.
Yeah, and talking about participating in research, can you turn off the lights one more time? So the reason why this is so important, and I really just want to talk about this idea about networks. So you can see the pattern that I put up there. Can you see that in the back? We did clinical trials for I will use the example of a lung cancer clinical trial. We did that study in the US, and we didn't find the drug was not effective. Then they did the trial in Japan, and they found that, oh, the Japanese responded one way or the other, and it was different from what we got in the United States. And now, the reason why everybody is so interested in finding the genome and doing all this genetic testing is that when you take people in the clinical trial, you actually take their tumor and you find out what it is that's going on in the tumor, and then you develop a drug. And that's what everybody is talking about, targeted therapy now. And if we don't have populations that are non-white participating in these trials, we're not going to know how those drugs work in this particular population versus others. So the last thing I'm going to tell you is that based on the fact that we continue to have really serious issues with who is getting into clinical trials, who is getting tested, we're really trying now to get data. Everybody, so the last thing I want to say is that how many of you have heard about big data? Big data, right? Everything you do on the internet, on Facebook, people are collecting information about you, right? And the question is, can we collect the right information that can really allow us to drive the innovation that will allow us to get the right treatment for the right person, especially women of African ancestry, men of African ancestry. And if you don't participate in that, it's going to take us much longer to get there. Thank you.